Yes. Then I ask Iris Grunwald to come to the podium.
Jacques Busquet,
Tips and tricks to speed up your thrombectomy service.
in fact, Jacques Busquet was not able to come because of personal reasons. So now we have Iris on the floor.
Thank you very much. Perfect. Thank you, Ivo. Thank you, everyone. Tips and tricks to speed up your service. I'm going to speed this up so that we will stay on time. I do have disclosures, and that is that I am co-founder of Brainomics, the AI company that automatically detects stroke on the CT images, and co-founder of Invention. So, why do we need to hurry in stroke? Because per 6 minutes delay, there is a 1% lesser chance of a good outcome. And per 30 minutes delay, the patient will lose 1 point on the modified ranking score, where 6 is dead, 5 is a vegetable, and only 0 to 2 are being independent. So it is really about saving every minute where we can. Now, this is the pathway in every hospital. It doesn't matter if you're a hospital that is going to transfer to another hospital. It doesn't matter if you're the primary treating hospital. We always have those 6 phases. We have the pre-hospital phase, patient evaluation, imaging and diagnostic, and then we have the primary treatment, what I call advanced treatment, then being the thrombectomy, and rehabilitation, supportive treatment, intensive care unit. Okay, wouldn't it be good if a patient comes to know if it is a large vessel occlusion? Any idea what we could do? How could we speed up the service? How can we be prepared? Because it takes some time to get ready. Any idea? Anything we could do? Should we already contact the paramedics who are coming in? Is that a good idea? Probably yes. What could we ask them? What we really want to know is there any way to predict if this is going to be a thrombectomy case for us? And yes, there is. There are different scores. Many of you would have heard of the FAST score. The FAST score is a score that predicts if there's a stroke, not if there is a large vessel occlusion. But there is a different score, and I'm going to talk to you about the LAM score today. The LAM score is so super simple that you can ask it on the telephone to the paramedic team. So, facial droop, 1 point. Arm, plegic, 2 points, just a drift, 1 point. And the hand, the grip strength, 2 points or 1 point. So 5 is the maximum. There are other scores, but, and they've also been compared, but you need to be aware that a comparison is always, when were they compared? Was it done in the field? And then a new assessment done when the patient arrived in the hospital, by which time the symptoms could have changed. So we found the LAM score as a very simple score, and that is why this score was evaluated in Germany, in the Saarland, over 4 months. Over 1,000 patients were included, and in every single case, the LAM score was taken, and the question was at 8 primary centers, 2 thrombectomy centers. And the question was, A, is it feasible to introduce that in the whole federal state of the Saarland? And B, does it allow triage to a thrombectomy-capable center? And give me a guess about the specificity of the score. How specific do you think it was? Give me some guess. Any number. It was pretty specific. Any ideas? Give me a guess. Come on. What do you think? What percentage? 5%. Higher. Anything higher? 70. Higher. Even higher. New guess. Over here. What do you guess? Higher. Higher than 70. So 83%, so very close. So the score was had a predictive value of 83%. You can only top that with a mobile stroke ambulance with a CT scanner inside. So pretty good result. And that is what we use. So what we do is we ask the paramedic on the phone and say, give us the LAM score of this patient. And if this is a LAM score of 5, we will already get the cath lab ready. We will have a pre-alert to the team. And the next thing, which saves the most time, is to bypass any accident and emergency department. So what we do is we immediately meet in the CT scanner, and that is where also the treatment, the thrombolysis is done, and where the decision is done. So this is bypassing our hospital. You see, it was never intended to be where the ambulances come, but this is the dedicated thrombectomy space for only the thrombectomy transfers, where they go directly into the radiology department. Next way to speed up the service, this is where my conflict of interest comes in. But actually, it was invented at the time because of the time delays, because what normally happens, you need to find a radiologist, probably a consultant, who will then report the images. They're busy with something else, they're not findable. So an AI tool can really, really help you, and especially an AI tool, because when I came to my previous hospital, I started the service initially on my own 24/7, and I love sailing. And I was constantly called for cases which turned out to not be large vessel occlusions. So I wanted a software that actually says, yes, this is a case, and that will alert me only in those cases. So you can already see the infarct volume from the software, but in addition, you can see, is there a large vessel occlusion? And so that the software was also evaluated, many studies. The biggest one was done in the UK with a huge number of patients. Let me just see, 83,000 patients were included in the study. And it was found that the amount of thrombectomies increased by 55%, and the outcome from patients increased from 60% independent outcome to 48% independent outcome, with time savings to treatment of 49 minutes. So AI tools can make a huge difference. The other thing we found is that the more frequently you do a procedure, the faster you get. When I did my first thrombectomy, or my first 20 thrombectomies, I thought, oh, that's easy, it's not a big thing. But only after 50 thrombectomies actually did I get faster. I did the same evaluation for my boss at the time. I remember I was not allowed to publish that he also took about 50 cases before he got better. So nowadays, those simulators are so good that you can really practice those procedures. And again, what we do in our center, we also have the perfused human cadaveric model, where it has been possible to keep the anatomy open and practice procedures in real human cadavers. Steph is going to talk about that tomorrow, about how this can speed up time, because you can finally practice with the whole team complications and the actual procedure. And just as an example, right, that was before we even had the Mr. Clean study. We wanted to do a free-arm randomized study to withhold thrombolysis to patients and start with thrombectomy, and the Ethics Commission said, Iris, you need to have patients on the table within 30 minutes from CT, within 30 minutes from randomization. And I just come to the new center, and we practiced the pathway, and we took 1 hour, 40 minutes. And I thought, oh my God, we're never going to be able to. And what we did is we did simulated practice runs. We divided the team into 2, and we said, you practice this, and you practice on the other side. You're going to compete against each other, and whoever wins gets a bottle of champagne, not sparkling wine, champagne. And we came to real-life scenario of 20 minutes from CT to arterial puncture. And nowadays, I mean, what we're really aiming for is within 8 minutes from decision to arterial puncture. That's the time we're aiming for. And you can only do that if you have several practice runs, and what better way than to do that in a simulated environment. Now, communication. Anyone who's involved in stroke treatment, you know how many people and how many calls need to be. On average, it is 58 communications, 58 calls you need to do. You need to organize, see if there's a bed. Need to have an anesthetist, probably an anesthetist assistant. See if the room is available, if there's someone else doing a procedure. Is the operator in the room? The operator for the thrombectomy, is there a nurse? Is the doctor, intensive care unit? You may need to reschedule all the patients that you have to cancel for the next procedures. Then previously with COVID, the donning, we need to test the anesthetic machine. Radiographer needs to be in place. Operator to check that the images at the CT, and you need to have the whole stroke team. So is there a better way? We were having lots of communication issues, lots of delays, people not having their phone, bleep system not working, waiting for someone to call back. And that is when we implemented a new communication tool, which streamlines the pathway and lets us have already the contact with the paramedic. So our pathway is patients talk to the paramedics. An NHS score or LAM score is a 5, high score. We alert from an NHS score of 10 or a LAM score of 5. And then the anesthetist, the cath lab team, everyone is already in the pre-alert. Let me show you how that works in the film. So patient is found in the field. Patient is looked at in the ambulance. And contact to the neurologist, stroke consultant. So he now got the message. He can now dial in and by video assess the patient in the ambulance to make a more informed decision on whether or not this is a case. And if he thinks this is a high LAM score, he now alerts the rest of the team. During my previous talk, that was the phone that went off. It works everywhere around the world. And even if I've got the phone on silence, it will override it and I will get the alert. So again, here the anesthetist, we have patients at ICU, the diagnostic radiologist who would do the normal reporting, the study nurse or thrombolysis nurse. So with one click of a button, everyone is immediately informed. Interventional team here in the cath lab, and they see all the information that was put in. Anesthetist now also getting the message, how far is the patient away. At this stage, the patient is not in the room, but the radiology technicians can already prepare the CT scanner. We know how far the patient is away. As you saw, our direct bypassing of A&E directly parked in front of radiology. Patient comes into the center. And now we need the information that the patient has arrived. So Raj is now getting the information, patient has arrived and is coming. Anesthetist running to come. And the room is already prepared. We do not open the expensive devices yet. This is before the CT angio. Now we have the CT angio. We know that there's a confirmation. We can now, via video, immediately communicate.
Yes, we can do. Patient is very cooperative. We can do without general anesthesia.
And so immediately I can call someone in, I can video call someone in, we can have a group conversation about the patient. If there were any new information, like here, say patient is COVID positive or negative, or patient has antiplatelets, that message would directly appear with us in the cath lab. Procedure is being done, and after the procedure, for the post-procedural care and the coordination, that can be put on. We could also link it to the blood pressure. It is linked to the Brainomics app, so we can see the images in the software, post-procedure care, and also can be documented on there, and feedback to the paramedics about the outcome of the patient. And to finalize, the next thing, of course, to make a service faster is a mobile stroke unit. You can see Professor Fassbender, who already had the idea in 2003. And the first mobile stroke unit in my old department in the Saarland, University of the Saarland, was on the road in 2008. Nowadays, mobile stroke units are in many of the guidelines and have been shown to be both cost-effective and beneficial to patients. This is what the mobile stroke unit looks like from the inside. You see the small CT scanner, point of care, video conferencing, and just it's a short thing. It's ambulance going across. CT scanner, point of care. Okay, so in summary, pre-alert, predictive scores for large vessel occlusion, bypass A&E, AI-assisted image interpretation, a structured communication, and ideally a communication software, and if we can, a mobile stroke ambulance. Thank you so much for your attention, and I probably see many of you also at ICA in Frankfurt in June. Thank you so much.
Yeah, thank you so much for this presentation. And as you mentioned in the beginning, yes, time is brain. And so every minute you can gain, yes, is helpful for the patient
Yeah.
to rescue brain tissue. Have you any questions?
If we have just 15 minutes less, out of those, 39 patients will be less disabled and 25 more patients will have an independent outcome. So it is really so much about shaving off every minute. And that is where, again, working together as a team, working together with cardiology, who've already got very fast pathways, has helped a lot in order to help us see what are the other things, thinking out of the box where we can shave off time.
That's amazing, really. Excuse me. This is amazing, congratulations. And can you tell me how many years it took you up to build such a network?
3 months. So, so bear in mind, so our center now, so there are not enough neuroradiologists in the world. So what we do is we train other specialities. So in my previous center, we had a joint service with cardiology, where we set up the service with cardiology. In my current center in Dundee, all my colleagues are interventional radiologists who previously had not done carotid stenting or thrombectomy procedures, and all have been trained up, and we immediately started the service. And the advantage really is when you start a service from scratch, you have the possibility of reshaping it. And you can set it up like immediately saying, no, we want to bypass A&E. We want to immediately set it up a different way. And again, also, we do not use perfusion imaging. We do not need perfusion imaging because we have AI software which gives us the core infarct volume already from the plain CT. We do not need perfusion first. And the other thing that we do is we do regular training. Yeah, we audit all our times, so every single time is audited, which again is much easier with the software because you just click on it and say CT done, CT angio done, yeah, vessel open, and to immediately be aware, is there anywhere where we can still improve or where things are not working. So in general, for a whole service, yeah, 3 months, you can do it faster. When we do the training, we usually have the training for 2 weeks, but the key is not training the individual, but training the team, because everyone needs to understand. And when I was talking earlier on about how we got faster by competing against each other, it only worked when we swapped roles. So I say, you're not the operator now. You're going to be the nurse. Yeah? You're going to be the anesthetist. It's being in each other's shoes and understanding where could we change things. And that made the difference.
Yeah. I remember when I started that more than 20 years ago in our town, yes, the problem was that when there was a suspicion that it's a stroke patient, the ambulances went to the next hospital. And that wasted time because not every hospital has a stroke unit doing this intervention. So we had then first to inform the ambulances when there is a suspicion it's an acute stroke, go to the hospital where the service is offered, and not to the next hospital, because normally ambulances go to the next hospital, deliver the patient, and so on. Yeah. And that is not helpful in these cases.
And I have to say, it does take the whole family, which is why, we're so close also with Ivo, with the rest of the team, because one does support each other. So we had a center in Poland that was starting their service. And of course, during the first cases, one tries to be there with video conferencing. My colleagues in the US would then go in if it's during the night, and to just give the support in the patient selection at the beginning. It's always this mental barrier after you've done it on the cadaveric model, on the human, even if you've done it on the human, there's still a barrier to now say, okay, now I'm going into the real patient. So it is quite helpful, and Klaus, you've been there as a proctor. So with the World Federation, we're trying to support each other, and as I said, it's a not-for-profit organization where we're trying to support those centers amongst our family and our team of like-minded people to provide a multidisciplinary service that is covering from stroke physician, neurologist, neurosurgeon, vascular surgeon, because we can all contribute to having less of those strokes. And it's such a big disease that we can only work together.
And very important is also from time to time to inform the public, the normal population, because otherwise, yes, the son will say, oh, Father, why don't you speak anymore? Yes? And so on. So until in the family or in the private field, yes, the idea comes, oh, it can be a stroke, yes, and call an ambulance.
Yeah.
Yes? Also, that is important. Therefore, from time to time, not every day naturally, but from time to time to go into the public and, yes, remind them how important it is to detect.
And everyone here in the room would have the catheter skills. Yeah, we are working with the same wires, same devices. Yeah, it is so similar in going to there. It's a bit about patient selection, choosing where to go, knowing some differences about the arteries, the injection technique, as Ivo was saying, in a small air bubble could be lethal in the patient's brain. But from the skill set, we all have the same skill set. We've all been working with catheters and wires for years. So we are very close to that. And I think it is the only way working together how we can tackle this disease.
Good. Yes, so thank you. Yes. In my program, that was the last talk. I don't know if it's finished.
Good.
Yes. So then I wish you a wonderful evening, yes, with a glass of champagne, and enjoy it, and until tomorrow.